Hello everyone, I'm very happy you've joined us today for the Gastroenterology section of the Step 2 High Yield series. I am Niket Sonpal, one of the co-authors of Master the Board Step 2 CK. We're going to begin our lecture with the esophagus, specifically disorders that affect swallowing. Now before we get to the meat of the matter, let's review a few definitions. The first is dysphagia. Dysphagia means difficulty swallowing. The second is odynophagia. This means pain while swallowing. Both dysphagia and odynophagia can lead to weight loss. Therefore, you can't use it to answer the question, what is the most likely diagnosis? However, if you combine weight loss with anemia and heme-positive stools, now you've got alarm symptoms. Then you know you need an urgent endoscopy. This little factoid right here is very high yield and very popular on the Step 2. Achalasia is the inability of the lower esophageal sphincter to relax from a loss of a nerve plexus within the lower esophagus. The etiology for many patients is unclear. A small proportion occur secondary to other conditions, such as cancer or Chagas disease. They all have in common aperistalsis of the esophageal body. Remember, Chagas disease is recent travel to South America with new onset dysphagia. Chagas is caused by the tropical parasite Trypanosome cruzi. Diagnosing achalasia, look for a young patient under the age of 50 with progressive worsening to dysphagia to both solids and liquids at the same time. There's no association with alcohol and tobacco use, and they will typically complain of regurgitation and halitosis. The best initial test in achalasia is a barium swallow or esophagram. It will show a tapering at the distal end known as the bird's beak sign. Here's a side-by-side comparison of a normal esophagus and one that is afflicted with achalasia. Notice the marked dilation of the esophageal body proximal to the LES. The most accurate test in diagnosing achalasia is manometry. In manometry, a probe is placed into the esophagus that measures the pressures of the concentric and longitudinal muscles. The hallmark finding you need to know for the USMLE is the following phrase. There is incomplete relaxation of the LES in response to swallowing. There is also high resting LES pressures and absent esophageal peristalsis. A chest x-ray to diagnose achalasia may show abnormal widening of the esophagus, but it's neither very sensitive nor very specific. Chest x-ray is never the right answer to diagnose achalasia. So if you see it as a choice, cross it out. An upper endoscopy for the diagnosis of achalasia has low yield because it shows normal mucosa. However, if there are alarm symptoms such as anemia, heme-positive stools, and weight loss, you must do an EGD. Now, achalasia cannot be exactly cured. All treatment is based on simple mechanical dilation of the esophagus, most specifically at the lower esophageal sphincter. The mainstay of treatment for achalasia is direct dilation or relaxation of the LES. This is a bougie dilation which is placed sequentially with larger sizes to dilate the LES. It's effective in 80 to 85% of patients. However, repeat sessions are necessary as it's not permanent. A second form of treatment is to inject botulinum toxin directly into the LES. The botulinum toxin interferes with the neuromuscular junction and causes relaxation of the LES. The problem is, it will relax the LES, but effects wear off in about 3 to 6 months, requiring re-injection. The third and most final treatment for recurrent achalasia is surgical sectioning or myotomy. These are for cases refractory to dilation and botulinum toxin. This is known as the Heller myotomy. Esophageal cancer is an important cause of dysphagia. Look for a patient who's over the age of 50. They have dysphagia with solids first, then progress to liquids. There's an association with prolonged alcohol and tobacco use, and many of these patients have had GERD for more than 5 years. The most accurate test for the diagnosis of esophageal cancer is endoscopy. It allows direct visualization and the ability to obtain tissue. Barium swallow may be the best initial test, however it only shows an abnormal contour to the esophagus and thus cannot diagnose as there is no tissue sample. Remember, if there's no tissue, there is no issue. CT and MRI is not enough to diagnose esophageal cancer. It can only be used to determine the extent of spread into surrounding tissues. PET scan is used to determine the contents of anatomic lesions if you're not certain whether they contain cancer or not. Surgical resection is the best thing to try, and it is the only cure for esophageal cancer. Chemo and radiation are used in addition to surgical removal as adjuvant therapy. For patients with very advanced esophageal cancer, stent placement can be used to keep the esophagus open, but note this is purely palliative and it's only to improve the symptoms of dysphagia. Diffuse esophageal spasm and nutcracker esophagus are clinically indistinguishable. They both are going to present with severe sudden onset of chest pain that's not related to exertion. The most important part of working up esophageal spasm is to make sure that cardiac causes of chest pain are ruled out. Therefore, you must get an EKG and stress test. What you'll find is they're normal. The best initial test is an esophagram. After that, you'll also learn it's normal. The most accurate test is the manometry. It's going to show abnormal contraction in various sections of the esophagus. The only way to distinguish between diffuse esophageal spasm and nutcracker esophagus is through manometry. Each one has a different abnormal contraction pattern. You don't need to know them for the USMLE. You just need to know that manometry is the most accurate test to distinguish the two. The problem with esophageal spasm is there's inappropriate contraction of smooth muscle. So to treat it, we must prevent just that. The first way is by using nitrates. What this does is it relaxes smooth muscle so it doesn't contract inappropriately. The second is through calcium channel blockers. What we do is we block the influx of calcium, therefore preventing the inappropriate smooth muscle contraction and preventing the symptoms of esophageal spasm. This is an esophagram that demonstrates the corkscrew appearance during the time of spasm. Not only is it a great study because visually you can actually see the spasm occurring, but there's also evidence to suggest that barium itself can cause the spasm. A 43-year-old man was recently diagnosed with AIDS. He now comes to your ED with pain on swallowing that's become progressively worse over the last several weeks. There's no pain when he's not swallowing. His CD4 count is 43, and the patient is not currently taking any medications. What is the most appropriate next step in the management of this patient? Is it A, an esophagram, B, an upper endoscopy, C, oral nystatin swish and swallow, D, intravenous amphotericin, or E, oral fluconazole? If you chose E, that's the correct answer. The most commonly asked infectious esophagitis question is an esophageal candidiasis in a person with AIDS. Oral candidiasis, or thrush, need not be present in order to have esophageal candidiasis. One does not automatically follow the other. Although other infectious agents such as CMV and herpes can also cause esophageal infections, what you must know is that over 90% of esophageal infections in patients with AIDS are caused by Candida. Empiric therapy with fluconazole, therefore, is the best course of action. Now let's go through the wrong answer choices. An esophagram wouldn't be correct because it only outlines the contour of the mucosa. It doesn't diagnose Candida. An upper endoscopy would be too invasive at this time. Because we know that 90% are caused by Candida, we start with empiric therapy first. If symptoms do not improve, then endoscopy is performed. Oral nystatin swish and swallow is not sufficient to control esophageal candidiasis. It really only treats oral. Intravenous amphotericin is used for confirmed candidiasis not responding to fluconazole. Therefore, it would be considered too much of a big gun. So remember, if a patient presents to you with the following presentation, start with fluconazole first. If their symptoms don't improve, then move on to endoscopy. Now let's go through the decision tree for a person with infectious esophagitis. If a patient presents to you with a CD4 count less than 100 and he has dysphagia or odynophagia, then over 90% of them will have candidiasis. We learned this on the last slide. You do not need to have oral thrush, remember this. So now what do? Well, you treat them with empiric fluconazole. If they've improved, you continue therapy with empiric fluconazole and you start heart therapy. That seems very straightforward. However, if the patient does not improve, then it can be two other causes. So therefore what you do is you perform an endoscopy and take biopsies. This is going to show one of two things. It will either show large ulcerations in the mucosa. This is going to be CMV. You treat CMV first line with ganciclovir. Second line is foscarnet. If you perform an endoscopy and you see small, shallow, multiple ulcerations, then that's herpetic esophagitis. You treat this with acyclovir. Now I want to show you an image of candidal esophagitis. The boards nowadays has been known to include multimedia images, so it's important for you to be able to not only know the information, but also to be able to see the information. This is an example of someone with diffuse candidal esophagitis. Those white plaques are the actual candida in the esophagus. Now, there are two important causes of dysphagia that are anatomical deformities. The first is known as Schatzki ring with accompanied Plummer-Vinson syndrome. Both of these can cause dysphagia. Here's an example of a Schatzki ring. A Schatzki ring is often due to acid reflux. It's really associated with hiatal hernia, and it's a type of scarring or tightening. It's also known as a peptic stricture of the distal esophagus. These Schatzki rings actually are associated with intermittent symptoms, not constant. The treatment for them is pneumatic dilation. As you can see in this image, there's concentric narrowing of the esophageal lumen. One favorite board question is steakhouse syndrome. It's dysphagia from a solid food, but in reality, the food isn't so big. It's actually stuck due to a Schatzki's ring. Plummer-Vinson syndrome is another type of anatomic deformity. It's a triad of dysphagia due to esophageal webs, iron deficiency anemia, and glossitis. It's similar to Schatzki's rings, except that they're more proximal in the esophagus. They're diagnosed the same way, however, by barium esophagram studies. The treatment is actually very different. It's not pneumatic dilation. The treatment for Plummer-Vinson syndrome is actually iron replacement. This actually could lead to resolution of the lesion itself. A Zenker's diverticulum is the only true diverticulum of the esophagus. It involves every layer. It's an outpocketing of the posterior pharyngeal constrictor muscles. The patient will state that he has dysphagia. His loved ones will complain that he has severe halitosis and regurgitates partly digested foods. Another presentation that's common is a patient who presents with recurrent right lower or right upper lobe pneumonias. This is from chronic aspiration. Here's an example of someone with a Zenker's diverticulum. Note the two different lumens. The best test for a Zenker's diverticulum is a simple barium esophagram. It's going to show a large outpouching in the posterior segment. Here's a live barium swallow. Notice that after barium is swallowed, there's an actual outpouching right there on the right-hand side of your screen. That's the Zenker's. There's no role for endoscopy in Zenker's diverticulum, as the endoscopy could actually traverse the false lumen of the Zenker's I showed you earlier and cause a perforation. That's something we don't want to do. Placement of an NG tube is also contraindicated due to the risk of perforation. There is no medical therapy. The resolution of a Zenker's is with surgery. If you've done rheumatology, we've been through scleroderma extensively. But just as a reminder, scleroderma is a chronic systemic autoimmune disease. It's primarily of the skin, but it can also be characterized by fibrosis. It can be a part of the CREST syndrome, calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, and telangiectasia. People with scleroderma present with symptoms of reflux. Scleroderma can also be a part of progressive systemic sclerosis. Keep in mind, it's a huge spectrum. The diagnosis of scleroderma is done by manometry. The treatment for it is with PPIs. Due to the amount of reflux a patient experiences, they also need to be screened for Barrett's esophagus. Mallory-Weiss syndrome is an important cause of upper GI bleeds after prolonged vomiting or retching. These repeated episodes lead to tearing of the mucosa with chest pain that's followed by hematemesis or black stool. Keep in mind, they do not have dysphagia. Most of the time, they're self-limited, and the best test for diagnosis is an endoscopy. One important fact that you need to keep in mind is that it's a non-penetrating tear limited to the mucosa. Here's an example of somebody with a Mallory-Weiss tear. There's no specific therapy for Mallory-Weiss. They usually stop on their own. However, for the really severe cases, we can actually inject epinephrine or use electrocautery via endoscopy to stop the bleeding. Now, in contrast to Mallory-Weiss tears, Boerhaave syndrome is a full-thickness tear and a surgical emergency. It typically occurs in patients who are alcoholics and who have had repetitive retching. The changes in intrathoracic pressure lead to a full perforation. On exam, the patients will say they had a sudden onset of chest pain, shortness of breath. They're going to have a positive Hammond sign, which is crepitus. This is subcutaneous air. It's a snap, crackle, and pop. The next best step in management, this is a surgical emergency, so take them to the OR.